Welcome to the Healing Pain Podcast with Dr. Joe Tatta. Each week, we interview top experts in physical therapy, pain science, and integrative pain care. You'll learn the most up-to-date information for treating and reversing persistent pain. This podcast is for educational purposes only and not intended to be used as personalized medical advice. And now, here's your host, Dr. Joe Tatta.
Hey there, friends. Thanks for joining me for this week's episode of the Healing Pain Podcast. Today, you'll get to meet my friend and colleague, Dr. David Hanscom. Dr. Hanscom is an orthopedic surgeon whose practice at one time focused on patients with failed back surgeries. He eventually quit his spine surgery practice to pursue his passion and present his insights into solving chronic pain, which evolved from his own battle and struggle with it. Dr. Hanscom has written 2 books on the topic of chronic pain and now guides patients more clearly through the complexities of solving chronic pain. On today's episode, we explore the connection between anxiety, PTSD, and chronic pain. It's a great episode to share, of course, with someone who's struggling with chronic pain, but healthcare practitioners, specifically orthopedic surgeons and primary care physicians. Okay, let's get ready and let's meet Dr. David Hanscom. Hi, David. Thanks for joining me this week on the podcast.
Thank you. I'm excited to be here.
I'm excited to talk about this topic. Pain and consciousness are 2 words that belong together, but we don't necessarily often see them together.
Right.
It's a big topic. The word consciousness means lots of different things, lots of different people. Some people don't understand what consciousness is and what that really has to do with pain with regard to the conscious and unconscious nature of things. I know you've done a lot of work around anxiety, both through personal experience as well as through your own research and writing books and treating people with pain. I think a good place to start is to just describe and explain the nature of anxiety as you see it.
Well, I'll just briefly reiterate why it's such a big deal to me. Because I went from being a fearless spine surgeon, and in 1990, I was driving across the 520 bridge in Seattle, and I had a panic attack. And that's, your heart races, you sweat, you feel like you're going to pass out. It's an incredible anxiety-producing situation. And I swear, before that moment, I did not know what anxiety was. And my thing was I was fearless. My attitude was bring it on. You could not give me enough stress. And I keep trying to tell my wife that normal people don't become spine surgeons. You just don't. So we're just incredibly good at mastering suppression. We're incredibly good about suppressing stress. We suppress anger. We express anxiety. And our thing is just bring it on. And you almost have to be that way to become a spine surgeon. And spine surgeon is stressful. So, but what I didn't know is that the suppression of emotions is a huge problem. And all of a sudden it exploded. It's like the top coming off of a pressure cooker. It just exploded. And from that moment on, for the next 13 years, I could not put this thing back in the bottle. I could not control my anxiety. And I thought it was psychological. And I went to, the world knows this, I went to 13 years of psychotherapy. Once or twice a week. That's a lot of psychotherapy. Wow. I thought it was a psychological issue. And I eventually developed what's called an obsessive compulsive disorder, which is the ultimate anxiety disorder. The prognosis for that disorder is horrible. It still is. And I didn't know what to do. And I, like many chronic pain patients, just lost hope. So I had severe anxiety. I had back pain, neck pain, migraines, stomach issues. My feet were burning. My mouth was burning. It was unbelievable. I had 17 different symptoms at that time. So I thought anxiety was psychological, and that's why I treated it as such. It turns out that anxiety is a response to a threat or a stress, just as danger. So it's your body's total response to the environment in order to survive, just as danger. Just like pain says danger, physically says danger, anxiety mentally says danger. And as you and I have talked multiple times, is that there's no separation of the mind and the body. It's just a unit. You cannot fly a Boeing jet without a computer. I'm sorry, the body can't survive without a nervous system coordinating the traffic. And so it's just a unit response to the environment. So anxiety is a result of a threat. It's not the cause.
That's a great way to open. I think the story that you so articulately tell is shared by many people that, of course, struggle with anxiety and as you mentioned, the various mind-body symptoms that go along with that. I'm just wondering, so you mentioned to be a spine surgeon almost requires you to push these emotions down, so to speak.
Absolutely.
And I'm just wondering, as you say that, because I've worked with many orthopedic surgeons, many who do incredible, much needed work. I'm wondering the place you see, because orthopedic surgery is, I mean, physical therapy can at times, it's changed over the years, but can at times be very mechanical, so to speak.
Right.
Person comes in, we give them exercises, certain weight, certain reps, et cetera. It's in a more therapeutic context. I'm, trying to articulate a point, but I think orthopedic surgery can be very similar. Person comes in, take an x-ray of their knee or take an x-ray of their back, do an MRI, identify a structural deficit, do the surgery, they exit, so to speak. And then, of course, there are hospitals and medical systems have quotas for professionals to work under.
Correct.
And quotas typically don't ever ease up.
Right.
Most big companies, especially hospitals, like to see money increase over time because things are increasing over time. I'm just wondering, with regard to emotion regulation, which are common in cognitive behavioral therapies and mindfulness and third wave therapies, is there a place for that in the training of orthopedic surgeons? And how do you think the majority of your colleagues would respond to, okay, I'm going through an orthopedic residency, it's stressful, I'm learning all these things about, the basic science and how to perform surgery. Where does this fit in to my professional career?
Yeah, they should be taught probably even in grade school, but for certainly by medical school, they should be flat out part of the curriculum. What happens in medicine in general, it's a very competitive world. People are very perfectionistic, which sounds like a virtue, but you know that perfectionism is sort of a disaster, right?
Yeah.
So it's always that not good enough, not good enough, not good enough. So that drives you to the top. The same drive takes you right down the other side. So the burnout rate in physicians right now is between 60 to 70%. Burnout physicians do not perform well. And when I give lectures, I may have 19 medical colleagues dead from suicide.
Mm-hmm.
That's a lot of people.
Yeah.
The incidence of suicide amongst physicians is about twice that of the national average in men and 4 times the average in women medicine doctors. And what happens is suppressed stress, it's suppressed emotion, it is suppressed anxiety. What kills people is anxiety, because here's the deal. The antidote to anxiety is control. Anxiety says danger, and you control the situation yourself to solve the anxiety. When you lose control, you become angry.
Mm-hmm.
Right? You kick in more chemicals to solve the problem. So what anger is the final last-ditch effort to regain control, and it is destructive. The ultimate act of destruction is self-destruction. Mm. So suicide is not an act of depression, it's an act of anger. And so I watched myself, in my book, I'm pretty clear I was suicidal. When I talked to them, I'm very close to a lot of these people, unfortunately, that committed suicide, and it suppressed anxiety. Yet when I give a lecture on burnout, when I use the word anxiety, everybody wants to just drop right through the floor. Mm. So what should happen? And then on top of that, we are under incredible stress, horrible hours, horrible demands. We're walking a tightrope literally every day of our life, especially spine surgery. I remember after doing 3,000 surgeries, I'm going, well, when does the anxiety disappear? Mm-hmm. So I just stuff it, do the next case, and stuff it, do the next case. But the problem is complications happen. You have to come to that same spot on the next case. So you suppress it. So what you do, you develop a cumulative PTSD. I never can understand why a significant number of spine surgeons would quietly quit practicing spine surgery at about 5 to 7 years into practice, but they couldn't suppress it anymore. So the key issue is so what I taught my fellows starting in 2006, I hired my golf instructor to be my performance coach. We basically taught mindfulness-based surgery. So by connecting to the move, so by suppressing anxiety, you're going focus, 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 but your attention's on focusing, it's not on the actual move. So as you know, with mindfulness-based movements, we used to drop our shoulders, take a breath, and we just go to light touch. And so by connecting to the touch, we're connected to every move. Instead of having thousands of thoughts in our brain throughout a case, in a 10-hour case, I might have like 5 distracting thoughts. Mm-hmm. My complication rate dropped probably by 80%. Mm. But it was about connecting to the move. So the answer is, final I can talk about this one for a long time, but
Yeah.
what's so perverse about medicine right now, we're being hired, controlled, and monitored. If we seek any help for managing stress, so first of all, we're not taught stress management tools. If we seek any help of any way, shape, or form in medicine, we're sanctioned.
Mm.
So we're an incredible pressure cooker. We're not given stress management skills. We're sanctioned if we seek any assistance at all. They say that you don't, but they'll take away your license. They'll take away hospital privileges. And it's become really rough on physicians right now. And that's where I'm actually concerned about the medical system completely dissolving right now, because doctors are quitting. I don't blame them. I went from a horrible burnout for about 10 years. In other words, I would call my time in chronic pain a true burnout. People don't call it chronic pain, they call it burnout, but it is burnout. It is chronic pain. So I came out of it, and the last 10 years of my practice were incredible. I was so excited about going to work. I was able to connect with myself, my patients. I mean, seeing patients that have no hope get back their hope and their life and thrive is incredibly rewarding. I loved it. So I went from the darkest of the darkest hole to just be totally excited and inspired by my patients. And as you know, I quit spine surgery about 2 years ago to bring these concepts out into the real world or into mainstream public opinion, because chronic pain is solvable, anxiety is solvable, but you have to get the right concept of what it is before you can solve it.
That's right. And I have a lot of more questions for you about anxiety and the nature of anxiety with pain. We were on a little bit of what I would term a wonderful tangent, because I'm really enjoying this conversation with you about spine surgeons and just orthopedic surgeons in general. And I want to just stay here just for another moment, if I have your permission for
Yes.
that. There is a term in the literature which is called vicarious PTSD.
Right.
And vicarious PTSD is basically any healthcare worker that, in essence, is working with people who are suffering, which would be psychologists, physical therapists, really everyone, physicians, everyone, but especially in the chronic pain world.
Right.
That each day, as you work with these patients, in some way, you're subjecting yourself to a small or potentially a large dose of PTSD.
Correct.
Now, in my mind, I'm also connecting that to the fact that I really believe all of us who've come to healthcare want to help people.
Right.
We want to serve people on the highest level. And then as a spine surgeon, when we look at the outcomes, the positive outcomes with regard to various types of spine surgery, they're quite poor in general. Outcomes are not very good just from spine surgery alone. And you have people coming back to you. Well, you have, first of all, I think many physicians say this is going to quote unquote fix you, this microdiscectomy, this fusion, this laminectomy, et cetera. And then it doesn't work. And then people come back to you, hey, doc, this didn't work. I still have this pain.
Right.
And sometimes the pain is worse, so to speak. So I'm wondering if that vicarious PTSD kind of rings true to you.
Oh, it's horrible. I mean, we know that literature shows that the way you induce depression is repeatedly dashing hopes.
Mm-hmm.
Right? Okay, so you're promised something that doesn't work. The thing about spine surgery that's so horrible is that the success rate of a spine fusion for back pain, as you well know, is about 25%. Right. There's actually a 40 to 50% of making your pain worse after spine fusion for back pain. So the chance of making you worse is double the chance of making you better. There's not one research paper in 60 years that says spine surgery works for back pain. Not one. And there's multiple papers showing that mindfulness, pain clinics, ACT, CBT, all these things actually work. The problem, as you know, is that they're not covered by insurance.
Mm-hmm.
So we have known effective treatments. We're not doing those. So there's another type of burnout. So it is a post-traumatic PTSD because we keep feeling to the patients and ourselves. We're not fulfilling their needs. There's also one called moral injury. Have you heard of this one? As we're in the trenches watching patients undergo procedures that the hospital administrators actually know don't work. They actually know that. The data says these procedures don't work. They actually monitor us on productivity on procedures that don't work. And so we're watching these patients be damaged. There's not much we can do about it, honestly. I finally had to quit my practice to do this because I was so under the thumb of this hospital with the computer systems that monitor every keystroke that we do. So it's become very intense. And that's why I really worry about the medical system in general. That's where with the COVID pandemic, we're harvesting the results of an illness model as opposed to a wellness model.
Yeah.
And so we've got to switch gears. And this is probably the time to do it in the midst of this pandemic.
I agree. And in so many words, you're not saying that we should not do spine surgery at all.
Right.
You're not advocating for that. Is that correct?
Correct.
Right.
I'm a surgeon, but I will say that if you actually, I think you've heard me use the word prehab.
Yeah.
I mean, there's lots of data that shows if you prep your patient for surgery, that the surgical outcomes are spectacular. But the data also shows that only 10% of surgeons, both neurosurgeons and orthopedic spine surgeons, are acknowledging that data before they do surgery.
Yeah.
And many times major decisions are made on the first visit. It makes no sense. So I started to prehab my patients, rehab before surgery, for about 8 to 12 weeks before every elective procedure. Patients started canceling the surgery, even with surgical lesions. At the end of my practice, I was only operating on 4.6% of my patients because they get better.
Mm-hmm.
And then when we did the surgery, their outcomes were spectacular. So it's not hard to do. But I want to say one final thing, going back to the burnout part of it. And you already know this. So with your physical therapist or physician of any specialty, is actually mind-numbing repetition.
Yeah.
I mean, there's only so many things we can do. What makes medicine infinitely interesting is actually talking to the patients. The patients are incredibly interesting. So by not with the business of medicine, limiting our time with the patients, not allowing us to talk to the patient, that's a major factor. The patient's not being heard. We don't know them. You don't know us. There's no energy there that keeps us going. So one of the biggest factors reversing burnout is actually talking to our patients. And we're in a horrible cycle right now.
No, I agree 100%. I think a lot of what you're talking about really points to things I talk about, things you talk about, some of the mindfulness and acceptance-based approaches to what's happening, how they impact not only practitioners in positive ways, but how they can also impact patient outcomes and then patients directly. Right. And as you mentioned, most of it probably centers around the therapeutic relationship, which is ultimately what you're talking about. So getting back to that concept of anxiety and your story that's wrapped in anxiety, which eventually turned into a panic disorder and led to, more grave consequences. Why do you feel that anxiety is the pain, so to speak? Because some people would say, well, pain is the problem. Anxiety is the mediator, so to speak. But really you're saying anxiety is the problem and pain is the mediator.
Right. You have an impulse you put your hand on a warm surface and your brain signals a little bit of danger. So pain can be too bright, too loud. It can be lots of different things, right? What is pain? Anxiety is just the mental manifestation of danger. So what happens, remember, anxiety and pain are the output of your brain. It's not the input. Remember, your brain's gathering sensations from touch, feel, sight, vision, smell. All those have ranges that are safe versus dangerous. The way every living creature survives on this planet, from the bacteria to mammals, is that we seek safety and avoid danger. So your body's processing 40 million bits of information per second to keep you safe. It's on automatic pilot. My pupils dilate and constrict. My mouth moves automatically. I shift to my chair. All that's automatic. My cat has the same system. She, stays alive. She hunts. She looks at different things. She avoids danger. She likes to be held. So those are all things that animals do, including us. So what happens is that humans have language. That's why I think chronic pain is a disease of consciousness. I mean, there's very few animal models for chronic pain. So remember, pain is critical for survival. Anxiety is critical for survival. If you didn't have anxiety, you wouldn't survive. So what happens if you're threatened by anything? A car, a boss, a bully, intrusive thoughts, whatever it is, your body responds with a response that says survive. What I didn't realize until about a year ago, that also includes the immune system, which includes the inflammatory system. So since humans can't escape their thoughts, we're all subjected to sustained levels of those chemicals. So the difference between my cat and humans is that humans have a word called anxiety.
Yeah.
We put a word on it. So really all it is a survival, is a total body response to a threat, any threat. So what happens is that we have this word called anxiety. The problem is that the unconscious brain processes about 40 million bits of information per second. The conscious brain processes 40. 40 million versus 40 is a million times difference. So I tried mind over matter, didn't work. It turns out that suppressed emotions are actually more of a threat than expressed emotions. And so it's a complete mismatch.
So when you say mind over matter, what does that mean? Because that's an interesting concept that some people use. And
that's what I did. I was incredible. I mean, I'm telling you, my nickname in high school and college was the Brick.
Hmm.
So I thought it was a compliment. Well, guess what? It was not a compliment. So we don't like feeling anxious. We don't like feeling angry. So we just don't. We just stuff it. I mean, what else are we supposed to do? That's what we're taught to do. But I mean, you're stuffing this 40 million bits of information per second versus 40. It's a 1,000,000-to-1 ratio. And so in psychotherapy, I was trying to understand the idea that knowledge is power. The more I knew about my past and whatever, I could actually solve the problem. The problem and the situation turned out to be that the more I talked about the problem, my brain started to develop in that direction and actually reinforced it.
Mm-hmm.
So I'm going to ask you a rhetorical question that I don't expect you to know. I'm just asking rhetorically for the audience. Okay, so anxiety is just a sensation generated by the body's survival response. That makes sense?
Yep, makes sense.
I mean, there's different things that can threaten you and put on the survival response, but you have fired up metabolism, you have a fired up inflammatory response, adrenaline, cortisol, all these things are on fire. You're hypervigilant. So if you can't escape your thoughts, and you can't deal with this with rational means because it's such a mismatch, how do you lower anxiety?
My perspective is you learn to relate to your thoughts in a way that's different.
Okay, so that's a technique. So it's a rhetorical question. So I try to get this down to really simple answers. That is a way of doing it. But the bottom line is that you simply lower the levels of stress chemicals,
Right?
Whatever it is. So changing your thought patterns is one way of doing it. What happens, for instance, what we found out this last year working with Dr. Porges of the polyvagal theory is that deep breathing actually stimulates the vagus nerve, which is anti-inflammatory.
Mm-hmm.
It turns out that humming stimulates the seventh nerve in the back of your throat, which stimulates the vagus nerve, which is anti-inflammatory. Certain music like lullaby actually stimulates the vagus nerve. Mindfulness, meditation, your interventions, nice massage, all stimulate the vagus nerve. They give you what's called, Dr. Porges calls it cues of safety.
Right.
And you mentioned this earlier really quickly, but I'll mention it again, that the number one factor in healing chronic pain is your relationship with your provider, physical therapist, psychologist, physician, surgeon, whatever it is, you want to feel safe. And there's not that many places in life that we feel safe. You know, family may not be safe, your workplace may not feel safe, you may not feel safe with your own thoughts. So there's techniques to separate yourself from your thoughts, use means to calm down the inflammatory response. And remember, there's three parts to it. You have the actual output, which can be either threat, stress chemicals, neutral or safe. Then you actually have your actual nervous system, which can be sort of calm or hyperreactive.
Mm-hmm.
Then you have the input. So I put together a process called the Doc Journey, the Direct Your Own Care Journey, which is the evolution of about 15 years of experience of people getting better, including my own experience. We now know the neuroscience much better, but you can't just jump from pain to happiness in one step. You've got to understand the whole process. And then there's direct ways of calming down the nervous system. But what you're doing is that whenever your stresses overwhelm your coping capacity, you develop symptoms. And so you can do two things. You can learn to process stress in a way that's not so impactful on your nervous system, or you can increase the resiliency of your nervous system. And when you get that balance back in place, and the symptoms disappear. That's why chronic pain is solvable. Because once you understand the root causes of the interaction between your nervous system and the environment or your circumstances, once you learn how to process these two, then you can solve the symptoms. What medicine's been doing for a long time, we're treating just the symptoms. We don't have the time anymore to know our patients. We usually don't know their circumstances. And you and I both know really well that unless you know those two factors, the symptoms are going to continue to be a problem. And we have to do something quickly. There are 150 Americans with a chronic disease. 30% of those 150 million Americans have 5 or more chronic diseases. Mm-hmm. It turns out that every chronic disease is inflammatory. Cardiovascular disease, peripheral vascular disease, diabetes, hypertension, obesity, anxiety, depression, OCD, bipolar, they're all inflammatory disorders. It's all the same stuff. So again, your body's responding. It's a total body response to threat. And that's the essence of the problem. The solution comes down to creating safety, which means you learn how to control your body's chemistry. And that's why I did mention the title of this talk, anxiety is a disease, chronic pain is a disease of the consciousness. So I know we've strayed in a lot of different directions here, but let me try to bring this back together in one concept. Okay, remember my cat has that survival response. She gets anxious, but she doesn't have a word for it. So she takes physical action, she avoids the threat, problem solved. She lays down and takes a nap. So my boss screams at me and I go home. I don't just lay down and take a nap. What does my brain do? It keeps spinning away. Mm-hmm. It turns out that emotional pain and unpleasant thoughts have the same effect on your brain as a physical threat. But since we can't escape our thoughts, we have this ongoing repetition. So it turns out to be a programming problem, because what your brain does, it translates the environment into symptoms. So these mental threats or this ongoing consciousness fires up your immune system, fires up everything we just talked about. And so my cat, animals do have, I think, some model of chronic pain, but I don't know of that really. I don't know that well enough, but probably pretty rare. But it's our consciousness and language that gives us impact on our nervous system that we can't escape. So it's a learned skill to simply learn how to control this process, control the reactions, learn the tools, learn the skills. What doesn't work, again, I'm a huge fan of psychology, but psychology is just part of the solution. I'm a huge fan of physical therapy, but physical therapy by itself isn't the solution. As you pointed out earlier, the mind and body are one unit, and you work on the body part of it, you work on the mental part of it. It's all the same stuff. So I'm working on my elevator pitch. I don't know if that came through clearly, but medicine has to get this diagnosis of anxiety correct. If I give a surgical patient, a choice of getting rid of their leg pain or arm pain with surgery, or getting rid of their anxiety, guess what? They want to get rid of the anxiety. They can sort of tolerate the pain, but they can't tolerate the relentless anxiety.
Mm-hmm. So playing devil's advocate for a minute, if a mental health professional is listening to this, they might say, well, let's just have every orthopedic surgeon use the DASH form, which is a measure of stress and anxiety. Why should we just not screen for that, let's say? So screen for it and send everyone to mental health.
Well, 2 reasons. I'm just going to be blunt here. So first of all, you have to actually treat it. Because you can screen for it and do it. It's happened for decades. We go through a process of simply screening people, but we don't actually treat the anxiety and frustration. We sort of go through a process, maybe get a sniff or two from a psychologist. Remember, anxiety is not a psychological problem. It's a physiological response to the environment. And so there's a group of somatic psychologists who are now changing pretty rapidly. And I think 10-year psychologists can be completely differently because, well, you know this with your acceptance commitment therapy. We talked about that on our show, is that you train your body to be with unpleasant thoughts and emotions, and you calm down the chemical response, it's game on.
Right.
So it's a set of skills that the psychologists in general don't really have. They don't really understand chronic pain. They don't understand this body response. And again, remember, when your body is full of inflammatory cells, you hurt. You increase the nerve conduction. Those inflammatory cells, by the way, are in the brain itself. You actually sensitize the nervous system. So that's the problem, is that we're still, that's my message today, we're still treating anxiety psychologically where it's not.
Yeah, I did some work a couple of years ago with an ACT psychologist who's very interested in using the body or combining the body with ACT. And we did some wonderful things together, actually. And one day I'll write it up in a paper or a book. But one of the great challenges with it is we actually piloted to a couple of psychologists, and they basically said, because it involved placing your hands on people, all the psychologists, and these were psychologists from various countries, various states, they all said, we can't touch people. And, I wasn't talking about like, manipulating their spine, so to speak,
right.
with a grade 5 manipulation. These are just, kind of basic movements and gentle pressure and touch, and in a way that is appropriate, with informed consent as well. But they don't have it in their practice act, so to speak. Now, as you mentioned, things are changing a little bit. There are techniques like somatic experience. There are many different types of somatic experiencing techniques, but it's one of those things. It's almost like it's taken a while, and it's still happening for physical therapists to bring into their skill set the idea of psychological techniques. We're not psychologists. We don't want to be psychologists. We actually don't think psychology is the answer for chronic pain. It's a part of a bigger problem. And of course, if someone has a psychiatric comorbidity, then they should be seeing a mental health professional. But the idea of, when I've tried to explain to some of these professionals that touch, placing your hands on people, getting them to move in ways that are safe, is extremely powerful and actually a form of psychologically based care. And I think some of them know it on a scientific level, but there's really this just like, well, that's not what I do. I sit in a chair and I talk to someone, so to speak. And I'm not a big proponent of quote unquote what I would consider talk therapy. I think, as you mentioned before, if we're going to talk about anxiety, or if we're going to talk about pain, there's some pretty good research that it's going to create more pain and create more anxiety, or at least not help it in a certain way. So it's interesting how you're bringing up how really interoception and the body influences the safety mechanisms of the mind.
Yeah, I mean, I was shocked. And again, I started working after Porges of the polyvagal theory. I was shocked and flabbergasted. I knew that anxiety was a response to a threat, but there are hundreds, maybe even thousands of research papers showing that anxiety, depression, bipolar are all inflammatory disorders. Mm-hmm. They're inflammatory. Yeah. They're metabolic. And it has, I'm not, again, this is really critical. Because remember, anxiety is a word that describes a sensation generated by your body's response to a threat. And Dr. Porges hates the word anxiety, and I don't disagree with him. I say, look, Steve, this is sort of a bridge word, that this is a sensation people feel. They're using this word to describe it. But one of the first things we do with anxiety is we say, look, it's necessary for survival. It's not going away. You have to develop a working relationship with it. Because if you didn't have anxiety, you wouldn't breathe, you wouldn't eat, you wouldn't do anything. You have to have it. It's how we evolve, it's how we survive. And so there's just a way of learning skills to sort of process it, move through it, make it part of your life every day. But if you fight it or try to solve it or fix it, guess what? You're just trapped, totally trapped. So his thing is, the first thing we do with people when we deal with anxiety is, look, get rid of the word. Take the word anxiety out of your vocabulary. Just visualize a large thermometer on the opposite wall. Just visualize the elevations of your stress reaction. And if you feel anxious, then you just means drop it back down. And there's lots of ways of doing that, which you well know. So that's the key issue, is anxiety is what you have, but it's not who you are. And it's a gift. And once you can sort of make the separation, I would tell you, for me, the last year, since I've understood this much better, and sort of have this conversation with patients, just explain the nature of anxiety, they just drop their shoulders and go, I mean, I don't feel bad about this sensation. I go, no, it's necessary. And let me remind people is that it's a survival sensation. It's intended to be so unpleasant that it forces you to take action, because the species of creatures who didn't pay attention to this cue didn't survive. So it's not only survival of the fittest, it's also survival of the most anxious. I mean, really anxious. We are the most anxious, the anxious species of creatures that have lived over hundreds of millions of years, right? So the people that were sort of relaxed just didn't survive. Anyway, that's the key issue. That's why it's such a critical issue, because, again, the burden of chronic disease is horrible. It's crushing our society. We have mental health issues. We have physical health issues. All this the same stuff. And unless medicine can get this diagnosis correct, and I love the work you're doing, by the way. I mean, again, we can talk about this for a long time, but I read your book, which was very concise. Well, what's the name of your book again, Joe? It was called
Radical Relief.
Yeah, I mean, I loved it because it's very concise and just nails it right there. And there's just lots of tools that work. And what we're doing in medicine, we're just flat out hurting people because we're thinking, look, with this chemical reaction, we call it anxiety. If we can't find a structural problem for it, we say, well, you have to live with it. Not true. And then we start doing procedures that have nothing to do with the pain. So we're actively harming people. So I will say that the physical therapy group, the chiropractors, not so much the psychologists or physicians, but I would say the two groups I've worked with the most that I'm excited about have been the physical therapists and been the chiropractors. They have lots of knowledge about the body, how it works, how it moves. They have lots of now groups that actually train your profession on the neuroscience of chronic pain. Mm-hmm. So I'm excited about that. And I think I'm excited about the potential change, but mainstream medicine has to make this change a lot faster than they are.
Yeah.
But again,
definitely physicians like yourself writing books. You have 2 books, Back in Control, and then you have a new book. Do you really need spine surgery? I think those books raise awareness, of course. Episodes like this raise awareness, and I'm sure you get lots of inquiries as well as curious questions from spine surgeons who probably wonder what is this guy talking about. I want to go back to anxiety for a minute, because like pain, anxiety is a survival mechanism. So it's not going away. We cannot turn it off.
Right.
And you don't want to turn it off, because if you turn that off, many negative things would happen from that.
Right.
So when you work with people and you're helping them kind of reframe anxiety, so to speak, do you ever get to the place where you're helping them realize that, hey, you can actually use a little bit of anxiety to your benefit, so to speak? So whether that's almost like building energy. So a little bit of like anxiety before like a talk. Oftentimes I have a little bit of anxiety before I lecture at a conference. And I've learned how to kind of like rechannel that, as you mentioned, that thermometer on the wall. Instead of it kind of like relating to my anxiety, it relates actually to like energy and kind of purpose and excitement for what I'm about to do, so to speak. And I think, taking it back to maybe a spine surgeon, hey, having to be at the hospital at 4:30 in the morning and having, 10 spine surgeries lined up takes a little bit of energy and takes a little bit of concentration. Is there a way to use that anxiety in a way that's healthy for certain situations?
Yeah, no, the term I like to use is called focused force, right? I mean, you've got
Focused force.
Focused force.
I like that.
Right. I mean, you have to be alert to do spine surgery. You have to be alert to, navigate life in general, relationships. You have to read visual cues. But remember, probably, I'm just going to put a crazy number out there, like 80% of anxiety is probably unnecessary, because from ACT and CBT, cognitive behavioral therapy, that a lot of this anxiety is based on cognitive distortions. Mm-hmm. And that's why I think chronic pain is a disease of consciousness, because, Dr. Burns in his book, Feeling Good, talks about the 10 cognitive distortions, like should thinking, labeling, catastrophizing, things like that. So it's unnecessary anxiety. It's unnecessary elevation of your stress chemicals. So again, one of the tools, just one of them, is that as you understand these cognitive distortions, they become irrelevant. So then we actually need that alertness to do your job. You have so much more energy. And so, and the other thing is, since you're not burning up energy, unnecessary anxiety, I had plenty of energy in high school, but it was that nervous energy, right? Yeah. So I probably have 3 times as much energy now as I did in high school, because I'm not burning it up all the time. Anyway, so the term for me is focus force. So I like that.
I like that. That focus force really speaks to me, because when your attention is not focused and your awareness is not probably in the present moment, I guess we should say, and you're living in the past with stories, or you're anxious about the future, then there is no focus force. And I think that's why so many people with pain and anxiety really struggle with fatigue as well.
Absolutely.
The candle is just burning at both ends constantly. And, from, as you mentioned, from a physiological level, cortisol and other stress hormones are just constantly pumping your system, and helping with that focus force, as you mentioned, is a way to really take back your energy. And when you can take back that energy, then you're like, okay, wow, it's incredible that I'm actually getting older, but as I'm getting smarter and wiser, I'm able to use my resources in more concise and useful ways.
If you learn how to do it.
Yeah,
because if you don't learn, it actually gets worse as you get older, right?
Yeah.
But one metaphor is driving your car down the freeway in second gear. It's going to break down.
Yeah.
So you're going to mentally break down and going to physically break down. Of course, it's the same thing. And again, the body translates your environment into safety versus threat. There's over 30 different symptoms created by ongoing threat. So there's multiple physical symptoms, multiple mental symptoms, but it's all the same thing. It's all your body's response to the environment. And again, it's the state of your nervous system versus the circumstances. And that's where the action's at, is that interaction is right there.
I've been talking to Dr. David Hanscom. He has 2 books out. His first book was Back in Control. His second book is Do You Really Need Spine Surgery? Both excellent resources, whether you're someone with low back, spinal pain, or if you're a practitioner looking to learn more about David's unique perspective and his life experience as well. David, can you tell everyone how they can learn more about you and follow you?
Well, let me just tell you about this latest rendition of what's going on. I may have watched well over 1,500 patients go to pain-free. And chronic pain is not considered solvable, and it is. So there's a new rendition or evolution of the project called the DOC Journey, the Direct Your Own Care Journey. And you can access it at thedocjourney.com, thedocjourney.com. And it's a package of services which includes a set of lessons, which gives you a sequence of things you can do going from A to Z. And then has twice a week group sessions, which is very powerful in healing. We've had a wonderful time with this. There's teaching videos, there's webinars, there's access to questions being answered. There's also an app being released this week. So it's a whole, what we're excited about by understanding chronic pain better, presenting it more clearly, the group interaction, we're seeing people getting better much, much faster. We're so excited about it. And it's been a long time in coming, and it'll continue to evolve, but it's called the DOC Journey. And again, it's not just, this is, as you know, it's a set of concepts. It's not a 1, 2, 3 in your fixed mode. And the final thing I'll say is that, remember we talked about how people get bounced around, they get discouraged, right? So why would my process work? So remember, it's not about belief. I actually say, look, start with your disbelief. This is not about pretending things are good. It's not about believing in David Hanscom or Joe Tatta. It's about just digging into who you are, connecting to who you are. Then you start changing your brain. So it's a stepwise process that's been consistently effective. So I'm excited about what I like about your work is you've got it so concise. What we've now done with the Doc Journey, we've got it much more concise. And, your goal and my goal is both to get this energy out into the world somehow. And there's a lot of work to do. So yeah, I'm excited to be aware of your work, and it's good stuff.
Likewise, David. It's always nice to connect with you. Of course, as David mentioned, you can find out more information on that website, the Doc Journey. That's www.thedocjourney.com. And of course, you can find all the links on our show notes at the Integrative Pain Science Institute. Just pop on over to the podcast tab, and you'll find that there. Everything's transcribed. I want to thank David for being with us on the Healing Pain podcast this week. Make sure to share this episode with your friends and family and any practitioners interested in chronic pain, anxiety. And of course, if they're interested in learning to know if they really need spine surgery or not. I'm Dr. Joe Tatta, and we'll see you next week.
Thank you very much.
Thank you for listening to the Healing Pain Podcast with Dr. Joe Tatta. To subscribe to the podcast and learn more, visit integrativepainscienceinstitute.com. That's Integrative Pain Science Institute.com. Sign up to receive weekly updates, leave a review on iTunes, and share this episode with your friends.